Hi, I'm Charlotte Mao. I'm the curriculum director of Invisible International, and I'm talking today on the intersection of pandas and PANS with Lyme disease and Bartonellosis. I'd like to thank the Monte Calvo Family Foundation and the Level Healthcare Foundation for making it possible for me to give this talk for Invisible International's educational platform. My only disclosures are the institutional affiliations with the two foundations who I work for, and I have no conflicts of interest to report. So the objectives for today's talk are to review historical scientific background that laid the foundation for the concept of PANDAS PANS, including commonalities with Sydenham's chorea, to develop an ability to recognize and diagnose neuropsychiatric manifestations of Lyme borreliosis and Bartonellosis, and understand the significant overlap with PANS and PANDAS symptomatology, to review some key features of Bartonella infection, including concepts of latent asymptomatic infection and stealth pathogenesis, to describe proposed mechanisms of pathogenesis of PANDAS PANS, including I'm going to introduce my own personal hypothesis of how Bartonella might play a central role in more cases of PANDAS PANS than generally appreciated. And finally, to understand limitations of serologic testing and test interpretation criteria for the diagnosis of Borrelia as well as Bartonella infection, and the importance of clinical diagnosis of Lyme borreliosis and Bartonellosis. So some historical background on the road to PANDAS, which is pediatric autoimmune neuropsychiatric disorders associated with streptococcal infection. And the late 1980s and 1990s was a period of time when researchers at the National Institute of Mental Health were studying psychopathology in children with Sydenham's chorea, particularly the high prevalence of obsessive compulsive symptoms. And also noted in these children were other psychiatric problems, including increased emotional lability, motor hyperactivity, irritability, distractibility, and behavioral regression. These children commonly had psychiatric diagnoses such as OCD, oppositional disorder, separation anxiety disorder, ADHD, and anxiety disorder. And then in the early 1990s, there was a report from pediatricians associated with Brown University in Rhode Island, who worked at a pediatric clinic for ADHD and neurodevelopmental disorders. And this study laid the concept of laid down the foundation for the concept of post-streptococcal ticks. In their study, they noted that there was a tenfold increase in children with new onset motor tics, including 3 patients who had abrupt onset of tics temporarily associated with strep infection in the setting of the community strep outbreak. And in their patient population, 83 of them referred for ADHD and neurodevelopmental disorders. Those who had recent onset of movement disorder, which included tic, Tourette's, or choreiform movements, were 5.5 times more likely to have serum antineuronal antibodies. Also, children with movement disorders were more likely to have elevated strep titers than children without. So this again laid the concept of laid the foundation for the concept of post-streptococcal ticks. So collectively, this group of studies laid the foundation for the first description of PANDAS. And that was in this 1998 paper from Sue Sweeto and colleagues at the National Institute of Mental Health, describing the first 50 children they comprehensively studied with acute dramatic onset of OCD and or tics associated with group A strep infection. And while they focused on OCD and tics as the anchor symptoms for their definition of PANDAS, the children had a panoply of neuropsychiatric symptoms that occurred in a relapsing, remitting pattern. I won't read the list, but you can see that many of them overlap with the psychiatric symptoms the group previously described in Sydenham's chorea patients. Similar to the Sydenham's chorea patients, a significant proportion of children also had other psychiatric diagnoses, including ADHD, oppositional defiant disorder, major depression, and anxiety disorder. What I want to point out, highlighted in red, is that a significant proportion, 23% of the subsequent symptom exacerbations in these children were not preceded by group A strep infection. And 31%, so not quite a third of their cohort, did have a documented recent strep infection with symptom exacerbations. But the remaining 46% were considered only possible strep. And that was divided between 4% who had a recent URI and a known group A strep exposure, and the largest group, 42%, who had sore throat or URI symptoms with fever, but no group A strep testing was done. However, because of the historical precedent of Sydenham's chorea as a post-streptococcal disease, the concept of PANDAS was born. And the idea was that you have a pathogen, group A strep, in a susceptible, genetically predisposed, perhaps host, that leads to an immune response that can give you either Sydenham's chorea or neuropsychiatric symptoms consistent with PANDAS. Now, taking a step back to just describe Sydenham's chorea, which is one of the major manifestations or the major Jones criteria for rheumatic fever. It is one of the post-infectious complications of group A beta hemolytic strep infection that is proposed due to molecular mimicry, leading to autoimmunity. So the idea is that there is molecular mimicry between a protein in group A strep and a host protein, for example, in skin, heart, joint, or brain, such that immune responses to the strep result, in the case of Sydenham's chorea, in a cross-reactive antineuronal and autoantibody response in the brain. And chorea is characterized by abnormal involuntary movements, sometimes described as jumps or jerks or twitches, as well as muscular weakness. There's something called milkmaid's grip, where there's an inability to sustain a tonic contraction with the hand muscles. But less well recognized by physicians, but equally prominent, are psychiatric symptoms in Sydenham's chorea, as reported by Susan Sweeto and colleagues, and even going as far back as 1894 in this monograph by Sir William Osler, entitled Of Chorea and Choreiform Affections. And it's rather haunting to read Osler's words from 130 years ago as his descriptions of psychiatric symptoms in these chorea patients sound remarkably similar to children with PANDAS PANS. And you can see that these are just excerpts from his descriptions. A frequent complaint from the mother is that the character of her child is completely changed, with great irritability of temper and emotional outbreaks, may do odd and meaningless acts, which is OCD-like, and on. You can see here, I won't read through the whole thing, but the similarity was so prominent as to make certain researchers observe that the psychiatric morbidity of PANDAS is similar to, if not identical to, Sydenham's chorea. And that's Russell Dale, who's a prominent researcher in autoimmune encephalopathy and movement disorders. Quote from him. So it thus appears that the symptomatology of PANDAS PANS is not necessarily a new phenomenon that suddenly appeared in the 1990s, but rather dates back potentially even more than a century. So what happened is, as it became increasingly clear that triggers other than group A strep could cause the symptom complex that constitutes PANDAS, leading clinicians and researchers in the field revisited the model's criteria and changed the acronym from PANDAS to PANS, which stands for Pediatric Acute-onset Neuropsychiatric Syndrome. And this figure is from a 2012 paper by Sweeto and colleagues that introduced this revised concept of PANS. The new model recognized that there could be other infectious triggers of the symptom complex, not just group A strep, but also other microbes such as Lyme, Mycoplasma, and in this diagram they say others, which can include microbes such as Bartonella, viruses have been implicated, influenza, varicella zoster virus, and even non-infectious triggers such as environmental toxic exposures or metabolic disorders. In addition to recognizing that possible etiologies were more numerous than just group A strep for these PANDAS-PANS cases, with the transition from PANDAS to PANS, it was also recognized that there was a broader array of associated symptoms. And here are listed the diagnostic criteria for PANDAS on the left and PANS on the right. Again, the abrupt dramatic onset of OCD was still one of the two defining core symptoms, but tics were removed as a core symptom and relegated to an accompanying category of motor abnormalities. You can see at number 6. And in its place, severely restricted food intake, or basically an anorexia-like presentation, was substituted. This is a less common PANS manifestation, but it is striking in its presentation when it does occur. It's often in the context of obsessional food restrictions for only foods of a certain type or texture, say, as well as fears of vomiting or choking. In most of these children, it is not associated with body image distortions that are seen in classic anorexia, but patients can lose alarming amounts of body weight. And then I won't go through the other symptoms that you can see listed there, but basically for PANS criteria, you need to have at least 2 of the following categories. And I'll just mention that in terms of sensory abnormalities in number 6, that includes often sensory processing problems. So children can suddenly develop hypersensitivity to, say, textures or sounds or to being touched. And for motor abnormalities, of course, tics, as we previously mentioned, but also in general, psychomotor agitation is often seen. So these kids are very fidgety and constantly in motion. Like any disease, PANS can range in severity, but the words on a page like this don't begin to describe how debilitating and terrifying and completely life-altering this condition can be for both child and family in severe cases. Families really are in desperate straits when these children are severely affected with this condition. This cartoon shows different doctors as so-called blind men examining an elephant patient with a PANS presentation, each pronouncing a different diagnosis based on their point of view. And I in no way mean to suggest that clinicians are blind to the big picture of PANDAS-PANS, but rather want simply to acknowledge that each of us likely views the condition with our own professional biases, and I'll acknowledge, including myself. And as an infectious disease physician who became educated on complex Lyme disease and Bartonellosis before learning more about PANDAS and the evolution of thinking of the field from PANDAS to PANS, I do recognize that I bring my own bias to my view of PANDAS-PANS. So turning the corner now to borreliosis and Bartonellosis, I first want to touch on some commonalities between these two infections and how in complex chronic illness, they are commonly part of a multiple hits model of disease, as you might call it. They're both vector-borne infections with more insect vectors recognized for Bartonella and Ixodes ticks being the vector recognized for Borrelia. But want to note that there are other potential transmission modes. So certainly animal scratches or bites have been reported with Bartonella, but also the possibility of congenital transmission is something to consider in pediatrics. The potential for that is recognized with Borrelia. With Bartonella, there is just a single case report in the literature involving a human twin birth. The clinical manifestations of both infections range from asymptomatic entirely to longstanding multi-symptom, multi-systemic illness with a wide variety of so-called atypical presentations and considerable overlap in symptoms, particularly neurologic, neuropsychiatric, and rheumatologic ones. Both infections have sizable asymptomatic seropositive rates. This indicates patients have had past exposure and infection, but not that they have actual disease. As a corollary to this, it's important to note the concept of latent infection with both these organisms and the possibility of later development of active disease. So this is analogous to, for example, syphilis, another spirochetal disease like Borrelia, or tuberculosis. And with commonly coexisting infections and considerable overlap in symptomatology, it may be difficult to tease out what is the direct cause of any specific symptoms. So how common are these infections? Well, Lyme is the most common vector-borne disease in the United States. Estimated 476,000 new diagnoses yearly is the latest estimate. But what I'm particularly interested in looking at here is the seroprevalence rate in healthy persons or blood donors in endemic areas. Studies that are older, before 2000, report seroprevalence rates in the US of 2 to 12%. And more recent studies, including a 2022 study on New England residents undergoing outpatient testing that was not for tick-borne disease, reported a seroprevalence rate of 11%. In non-US studies, there's a wide range in reported seroprevalence rates, ranging from 2 to 7% in pregnant women, and in blood donors, anywhere from 3 to 39%. There is a recent systematic review and meta-analysis that estimated the overall global seroprevalence of Borrelia infection to be 14.5%. And although North America was not one of the top 3 regions of the world, there was an estimated seroprevalence overall of 9.4%, so sizable, with a wide range in subgroups, from as low as 1.2% in the general population to 28 to 30% in a high risk or tick-bitten population. Similarly, studies of Bartonella seroprevalence in healthy controls have shown high rates of asymptomatic infection, either in blood donors or healthy persons, both children and adults. And I have circled in red the US studies, which tend to be somewhat older, before 1996. They reported rates varying from 2% to 29%. Non-US studies are circled in blue, and you can see a wide range from 8 to 62%. But I wanted to show all the different studies because you can see that really a sizable number of the non-US studies report seroprevalence rates well in the even 30, 40% and higher range. Now, stressing that this does not mean active infection, but shows past exposure and infection. So now a word about the pathogenesis of Bartonella, which has been sometimes referred to as stealth pathogenesis. This is a facultative intracellular pathogen. So it can be, but does not have to be intracellular. And the thinking is that there is a primary niche that is infected when the organism is transmitted. In this diagram here, it's a diagram of a flea depositing feces on the skin that then gets transmitted by dendritic cells in the dermis to endothelial cells here are being proposed as the primary niche that then contributes to later blood stage infection. Bone marrow has also been proposed as another primary niche. And a very key feature of blood stage infection is that Bartonella is able to invade and persist within red blood cells for prolonged periods. So it can cause a long-lasting and often asymptomatic bacteremia that's intraerythrocytic in reservoir hosts. And because these Bartonella are residing within red blood cells, they are protected from immune responses. So just doing a little review of immunology, mature red blood cells lack a nucleus, and thus they lack what's called major histocompatibility complex on their surface. And that is what presents antigens of intracellular invaders to the immune system, specifically to CD8 positive T cells. So intraerythrocytic Bartonella are not being presented to the immune system and can be quietly residing within the red blood cells. Post-antibodies, the humoral immune system will have no effect on these erythrocytic Bartonella, but they can contribute to preventing new waves of infection. Bartonella has also been shown to infect other cells such as macrophages, microglial cells, and pericytes. So that's all important for neurologic manifestations of Bartonellosis. Additionally, Bartonella has been shown to manipulate the host immune system by modifying host cell cytokine production, including inducing expression of an anti-inflammatory cytokine IL-10. This can likely induce a transient partial immune suppression and facilitate bacterial persistence. So Bartonella is really seen as a model of so-called stealth pathogenesis. And not surprisingly, then there can be very widespread clinical manifestations of Bartonellosis, as this organism can spread to many different organ systems, and you can see them represented here in this diagram. These are all manifestations that have been reported in the literature for Bartonellosis, additional ones listed in the boxes here. And the ones that are in brackets are ones where there maybe are only one or two case reports. But otherwise, all these manifestations have been well documented in the literature. I want to focus, however, on neurologic and neuropsychiatric manifestations. And as you can see here in this list, again, these are all manifestations reported in the literature for neurobartonellosis. And I should, one comment, I'm focusing here on Bartonella, but in fact, all these manifestations can also have also been reported with Lyme borreliosis, excepting the ones highlighted in red are either seen as being more specific for neurobartonellosis, or in the case of coma and status epilepticus, or in the case of anger, aggression, rage, and combative behavior, that has been reported in the literature with Lyme as well, but is generally seen as being anecdotally more characteristic or common with Bartonella infection. And then I wanted to show here the very sizable overlap of neurologic and neuropsychiatric manifestations of Lyme and Bartonellosis, Lyme disease and Bartonellosis, with PANDAS manifestations. And the similar manifestations are all highlighted here in blue. So there's definitely a flavor to these infections in terms of neuropsychiatric manifestations that is highly reminiscent of the types of symptoms that form the criteria for PANDAS and PANS, with the one caveat being that the acute, dramatic, sort of overnight type of onset that is sometimes described with PANDAS and PANS is not characteristic as much with Bartonellosis and Lyme borreliosis. So talking a little bit more about the pathogenesis of neuropsychiatric symptoms in Bartonellosis, psychiatric manifestations were described in the earliest reports of cat scratch disease encephalopathy, and even acute or abrupt onset of profound neurologic dysfunction, even coma, was described in some of these reports, followed in some cases by surprisingly prompt symptom resolution without sequela. And so to some of those early clinicians, that suggested the possibility of a toxic encephalopathy. Psychiatric symptoms were also described in HIV-infected patients with bacillary angiomatosis, which is a dermatologic manifestation that is really seen just in severely immunosuppressed patients like HIV patients. And the psychiatric symptoms included personality changes, marked depression, new psychotic symptoms. Initially, they were felt to possibly be related to some other opportunistic infections, such as toxoplasmosis. But later, when the mental status problems cleared with antibiotic treatment of the bacillary angiomatosis, the psychiatric symptoms were felt actually related to the bacillary angiomatosis. And other possible mechanisms include direct bacterial invasion of CNS tissue. Mentioned before that you can see intracellular infection of endothelial cells, parasites, macrophages, and microglial cells, which would all be related to CNS direct bacterial invasion. Also immune-mediated neuroinflammation, which is also the presumed mechanism in PANDAS PANS. CNS toxin release from the bacteria, as I mentioned before. And finally, vasculitis, potentially immune-mediated, has been hypothesized as a mechanism. I wanted to comment a bit on the anger, aggression, rage, and combative behavior in Bartonellosis, because that is a common symptom that can also be seen in PANDAS PANS patients. And this was something that was described in a number of reports of encephalopathy associated with cat scratch disease. So here you can see descriptions of very agitated, combative, and aggressive patients with cat scratch disease encephalopathy. In this was a case series of children with acute cat scratch disease encephalopathy. And the authors noted that there was actually a high rate, 39% of transient combative behavior that was striking enough that they commented that, to our knowledge, this behavior with this frequency is undocumented in any other type of encephalopathy. And here is yet another report in a young adult male of cat scratch disease encephalopathy associated with personality changes and aggressive, combative, violent behavior. Then rage outbursts were reported amongst multiple other symptoms, neuropsychiatric symptoms, in this report of Bartonella-associated PANS in a adolescent male. And it really is a just detailed clinically very highly informative description of PANS case associated with Bartonella infection. This young man had, you can see, multiple symptoms that are consistent with those seen in PANS, and was eventually diagnosed 15 months into the illness with PANS, with initial testing for Strep, Mycoplasma, and Lyme, and viral infections being negative or equivocal. And it wasn't until these stretch mark-like lesions that you can see in the photo were noted by a clinician on this boy's thighs and axilla that neurobartonellosis was suspected. So I'll be talking more about this in a second. And then testing at a specialty lab did document positive DNA PCR for Bartonella Hensley from blood serum and special, this is a proprietary enrichment blood culture called BAP-GM. And interestingly, Bartonella serology testing was negative for a number of Bartonella species. But the patient was treated with extended combination antibiotics for Bartonella and had a full recovery with all antipsychotic drugs being able to be gradually withdrawn and return to full functioning. Talking a little bit more about these striae lesions, I want to stress this because they are a very valuable diagnostic tool for clinical diagnosis of Bartonellosis when, say, a PANDAS patient might not have testing that supports a lab diagnosis of Bartonella. But if you see these types of cutaneous lesions, then you need to think about Bartonellosis. They were first described, in fact, by a pediatric gastroenterologist, Martin Fried, back in 2002 in a conference abstract. And you can see some photos here from some of these patients who were referred for chronic abdominal and heartburn pain that was associated with mesenteric adenitis and this striae-like rash. And interestingly, Bartonella Hensley DNA was found by PCR at endoscopic biopsies of gastritis or duodenitis sites of inflammation, while H. pylori testing was negative. This was somewhat part of, I would say, popular lore for about a decade. And then Professor Breitschwert and colleagues, about a decade later in 2013, reported the first demonstration of Bartonella Hensley organisms in striae tissue biopsy from an adolescent male who had a complex of symptoms that were related to Bartonella Hensley infection. And the organisms were demonstrated in striae tissue biopsies by immunohistochemical microscopy. And this group went on to do 2 additional reports of Bartonella-associated skin lesions in patients with neuropsychiatric symptoms. I'm not going to go into detail reading these, but just point out that in that second report on the right, the Bartonella-associated cutaneous lesions in patients with neuropsychiatric symptoms, there's some really nice photographic documentation of a wide variety of cutaneous lesions that are seen in these striae-like presentations. So PANS presentations have also been reported with Lyme disease. This was actually a report that at the time was not recognized as being a PANS-like presentation, but the history is consistent with and would meet criteria for a PANS presentation. This is a 12-year-old boy who had knee swelling that led to a diagnosis of Lyme disease confirmed by serology. He was successfully treated, but 2 months later became withdrawn and depressed. He had obsessive compulsive behavior where he was exercising compulsively and on a bike, and lost a large amount of weight. He was eating very little, was grossly depressed, and actually diagnosed with anorexia nervosa and admitted to a psychiatric hospital. And turns out that there was a young physician, a neurologist from Yale, who was moonlighting at the psychiatric hospital and recognized that there was a possibility that perhaps Lyme, with this child's history, could be contributing to his psychiatric symptoms. And so testing showed positive Borrelia-specific proteins on immunoblot testing, and there was also a positive Lyme ELISA or EIA. However, CSF studies and imaging studies were normal. The patient was treated with IV penicillin, and symptoms actually resolved very quickly and completely over the next several months, and the patient remained asymptomatic for 3 years at the time of this report. So this child would meet criteria for PANDAS with the OCD behavior and anorexia nervosa, the restrictive food intake, and the depression. Additional reports of PANDAS in Lyme, tick-borne disease, and neurobartonellosis include, here's a case report of a adolescent female with cat scratch disease, encephalomyelitis, neurologic symptoms, and severe emotional disturbances with periods of anorexia that were described as so severe and prolonged, she was fed by gavage for many days. This was a report from actually 1955, so an early report of cat scratch disease, encephalomyelitis. The next one is a German report of, again, an adolescent female who also was diagnosed with anorexia nervosa and was found to have Borrelia and encephalomyelitis, supported by CSF findings, and after antibiotic therapy, symptoms in CSF were near normal. And then there is a more recent report by Daniel Kinderlayer of an adolescent female, also anorexia nervosa, diagnosed at age 16 in this child who had a history of multiple tick attachments from an early age, as well as some psychopathology when she was younger, and fatigue and frequent sore throats with cervical adenopathy that could be relevant as well. And then at age 14, after an untreated tick bite, had worsening fatigue, impaired cognition, anxiety, depression, multiple symptoms, as you can see there, that can be associated with PANDAS, and also had erythematous striae in multiple locations. ID testing was notable for positive findings to corroborate Borrelia infection, as well as Babesia, microti, and mycoplasma. Bartonella Hensley testing was negative. The serologic testing was negative, but the patient was diagnosed with Bartonellosis clinically based on clinical symptoms and the striae-like lesions. And again, after treatment with oral and IV antimicrobials, symptoms were in remission for 2 years. Now I want to talk a little bit more about proposed mechanism for PANDAS pathogenesis. The presumed mechanism is, or the most commonly presumed mechanism, I should say, is molecular mimicry between a microbial protein and a host neuronal protein, resulting in production of cross-reactive antibodies that can cross the blood-brain barrier and target neuronal proteins, specifically in the basal ganglia. And there is evidence in a murine model that group A strep, which is the most well-studied of the microbial triggers, can be a trigger not only through molecular mimicry, but also through activation of Th17 cells, so type of helper T cell called type 17 Th cells. And these Th17 memory cells help control extracellular bacterial infections and fungal infections at mucosal surfaces by recruiting and activating neutrophils. But they have also been shown to play a role in the generation of immunopathology, characteristic of other autoimmune conditions, for example, MS and rheumatoid arthritis, by inducing the production of a variety of pro-inflammatory cytokines, including IL-17 and TNF-alpha. And there is a murine model that has shown that these group A strep specific Th17 cells can be found in the nasal associated lymphoid tissue of mice, which is basically an equivalent to the palatine tonsils of humans, where these cells have also been demonstrated. And in the murine model, this led actually to breakdown of the blood-brain barrier. That's because the Th17 induces this pro-inflammatory IL-17 cytokine, which disrupts endothelial tight junctions of the blood-brain barrier. And it led to autoantibody deposition, microglial activation, and the loss of excitatory synaptic proteins in the olfactory bulb, all demonstrated in this murine model study without any viable bacteria, without viable strep bacteria detected in CNS tissue. Interestingly, Borrelia burgdorferi lipoproteins have also been shown to induce production of IL-17 in helper T cells in both mice and humans. Then finally, also to mention, again, toxins do get proposed as being potentially a mediator of PANDAS. And in fact, researchers in one report speculated that the rapid response to antibiotic treatment of some of their PANDAS patients suggested more a toxin-mediated mechanism that they felt than a autoantibody immune response. So how can one explain similar PANDAS symptomatology being instigated or created by a wide variety of infectious triggers, or even non-infectious triggers as well? Well, the presumed mechanism is that there's some type of shared molecular mimicry involving a protein that is present in a wide variety of microbes and a host protein in neuronal cells. Just as one example, a protein called enolase has been proposed as potentially being related to post-streptococcal autoimmune CNS disease. This is a multifunctional microbial protein. It's a glycolytic enzyme, and it also is a plasminogen binding protein that is on both the surface and in the cytoplasm of multiple pathogenic microbes. So that includes group A strep, pneumococcal, strep pneumoniae. It's been demonstrated in Borrelia burgdorferi and Bartonella. Those are just examples of some microbes in which it's been demonstrated. And it does cross-react with human enolase that's on the surface of multiple cell types, including neuronal cells. So these glycolytic enzymes on the neuronal plasma membrane are involved in multiple roles: energy metabolism, cell signaling, as well as synaptic neurotransmission. And the thought is that autoantibodies against these neuronal glycolytic enzymes can contribute to post-streptococcal autoimmune CNS disease because of this shared molecular mimicry. And in fact, there was one report that did find that these autoantibodies to these neuronal glycolytic enzymes were more common in patients with Sydenham's chorea and PANDAS than in controls. Interestingly, this enolase autoantibody has also been hypothesized to interfere with glycolysis in neuronal cells as a physiologic basis, potentially for persistent symptoms in Lyme disease. There have been other antineuronal antibodies that have been reported in PANDAS patients. For example, anti-dopamine receptor and other autoantibodies in the so-called Cunningham panel. But there have been conflicting results from different researchers reported for these antineuronal antibodies in PANDAS. So in a multiple hits model of illness, it's possible that there could in fact be a combination of triggers that could be responsible, and it can be difficult to discern which trigger is in fact most implicated. And I want to propose my own personal hypothesis, which I see as a complementary hypothesis that involves the potential impact of what's called hemolysins from a wide variety of organisms, including group A beta hemolytic strep, on intraerythrocytic Bartonella. So let me explain. First, what are hemolysins? These are pore-forming, membrane-disrupting exotoxins produced by a variety of microbes that can actually lyse erythrocytes as well as other cells. Multiple bacterial species produce hemolysins, including group A strep, Staph aureus, pneumococcus, leptospira, and fungi as well. Aspergillus, Candida, and Stachybotrys are all known to produce hemolysins. Group A beta hemolytic strep gets that name beta hemolytic from its hemolysins, of which there are two main types. One called streptolysin S is the one that's largely responsible for what's called beta hemolysis that's seen when strep is plated on blood agar plates. This is actually how strep is recognized in microbiologic lab workup. And in that photo there, you can see three different types of hemolysis. With beta hemolysis, you see a full clearing of the red blood cells. So the red is completely gone around the colonies that are streaked on the plate. With alpha hemolysis, there's partial hemolysis, so you see some greening of the surrounding red blood cell agar. And then the third type of hemolysis is called gamma hemolysis. The other hemolysin that is in strep is known as streptolysin O. That one is well known for being the one that when you form an antibody to it, that is anti-streptolysin O, or ASLO, that is a marker of a recent strep infection. As I mentioned, hemolysins or beta hemolytic activity have been described for other organisms, including, interestingly, Borrelia burgdorferi. And in fact, some Borrelia strains, some non-burgdorferi Borrelia strains have been found to have genes for streptolysin S-like toxins. other organisms, such as mycoplasma and certain viruses, for example, influenza, do also have hemolytic activity, although it's via other mechanisms, which I won't get into here in the interest of time. So the hypothesis I'm raising is, could it be possible that red blood cell hemolysis might actually activate a latent intraerythrocytic Bartonella infection? So going back to what we talked about when in the slide about Bartonella pathogenesis, recall that red blood cells do not have a nucleus, and thus they lack what's called MHC1 molecules on their surface, major histocompatibility complex type 1, which is also known perhaps more familiarly as HLA markers, human leukocyte antigen markers. These can be thought of sort of like a flagpole that's on the surface of a cell, and when a cell is invaded by an intracellular organism, a part of the organism is raised up this flagpole, this MHC1 flagpole, to alert the immune system, hey, this is what has invaded me, come respond to this organism. But because red blood cells do not have this MHC1, they are unable to present antigens of their invaders at the cell surface to cytotoxic CD8 T lymphocytes that are involved in cellular adaptive immunity. So in this hypothesis, red blood cell hemolysis, the ideas could potentially result in a previously intraerythrocytic stealth Bartonella being so-called released, if you want to say, and thus in larger numbers, and thus being seen and responded to by the immune system. So symptoms and signs could then result from the direct effect of waves of liberated bacilli or from an inflammatory host immune response to these Bartonella organisms, or to both mechanisms. Do you want to say a little bit more about other infections that can potentially be associated with PANDAS, and potentially through activation of Borrelia or Bartonella infection? And in particular, have to talk about SARS-CoV-2 infection. Neuropsychiatric symptoms have been extensively described with SARS-CoV-2 as well as with long COVID. And this includes multiple case reports and case series of children or adolescents with PANS type presentations after SARS-CoV-2 infection, including mild or asymptomatic infection. So proposed mechanisms for these post-acute sequelae of COVID include autoimmunity. This is a common theme due to molecular mimicry between host and pathogen proteins. Also, the possibility of persistent reservoirs of SARS-CoV-2 virus or viral remnants, and also the possibility of reactivation of other latent pathogens. So that's been described with Epstein-Barr virus, other herpes viruses, as well as Bartonella and possibly Borrelia. Again, this is a multiple hits model of illness where a combination of triggers could be responsible. And so sometimes it can be difficult to discern which of those triggers is most implicated. But I want to just show here that there have been some recent papers showing, reporting reactivation of latent Bartonella infection post COVID infection. And I won't read the details here, but all to say that I think that this is something that definitely needs to be considered with PANS-like presentations in association with SARS-CoV-2, the possibility that perhaps there could be activation of latent infections such as Bartonella. or Borrelia, leading to these PANDAS-like presentations. Okay, so now I just want to talk a little bit about the commonly used Lyme and Bartonella serologic testing limitations. Not going to go into too much detail because the topic is extensively reviewed in some of the other accredited CME courses. And I would point you specifically to the courses listed here by Professor Monica Embers and Professor Ed Breitschwert. But bottom line, the message is that Lyme and Bartonella serology lacks sensitivity. The serology results provide evidence of past exposure and infection, but not necessarily active disease. So diagnosis must be based on clinical presentation with labs viewed as supportive or not of a clinical diagnosis. And sometimes it's necessary to do multiple tests at reliable labs because of limited sensitivity. I'll just comment in a little bit more detail about Lyme serologic testing. And this shows the standardly accepted diagnostic criteria for interpretation of Lyme Western blot or immunoblot testing. And this was first reported in the CDC MMWR from 1995. And what is surprising is that actually the interpretation criteria for IgG and IgM each are based on only a single study, which you can see highlighted in green is the study that serves as the basis for the IgM immunoblot criteria, and in yellow, the study that serves as the basis for IgG immunoblot criteria. And on the right is shown an example of an actual blot where the different so-called bands can be seen on a blot. And these actually represent antibodies to different proteins of the organism. So this just shows that rather than knowing what, simply counting up how many bands there are, it is important to know which of these bands are highly specific for Borrelia. And I just want to go into a little bit more detail on this one study that serves as the basis for the IgG immunoblot criteria, which is this study by Dressler and Steer, and it's from 1993. And Dr. Embers, Professor Embers, does cover this quite extensively in her course. But what I want to just point out is that the study consisted of two sub-studies, a retrospective study and a prospective study. And they were they were relatively modestly sized studies. And from the retrospective study, they generated their proposed IgG criteria that were eventually accepted as the standard criteria to use, and which require 5 or more of 10 select bands to be present. But in this study, when you actually look at what the sensitivity of their proposed criteria were for neurologic patients, you can see that in the retrospective study, late neurologic disease, it was only 84% sensitive, and in the prospective study, it was even lower. Neuroborreliosis was only 72% sensitive. This is in contrast to arthritis, where the sensitivity is much higher, 96 to 100%. So there actually were subsequently 2 independent studies that used reference samples from the Centers for Disease Control and used their recommended interpretation criteria and reported similarly low or even lower sensitivity of only 43% in one study and 44 to 74% in the other. Several subsequent studies have reported high sensitivity in the high 90s to 100% in late Lyme disease. But importantly, there is problematic selection bias inherent in the study design of these studies. And their inclusion criteria required that the patient have lab confirmation by CDC surveillance criteria, or even in some of the studies by a positive 2-tier serology in late disease patients. And furthermore, the studies that did separate out arthritis versus neurologic patients showed that there were few late neuro cases. In one study, it was only 2 patients, in another, it was 11. And in both those studies, half or more of those very few neurologic patients also had current or previously treated arthritis. So these details are very important because, as I mentioned before, the sensitivity of the Western blot IgG criteria are much higher in arthritis patients than in neurologic patients. Similarly, Bartonella serologic testing has limited sensitivity, and this basically shows that historically serologies for Bartonella, which commonly are IFA titers, the cutoff historically was considered titers of 1 to 64 or greater. But in fact, the cutoff levels used by different labs are not standardized. So that's one potential reason for varying sensitivity of testing in different labs. Also, it's important to note that most commercial labs test for only 2 species of Bartonella, and however, more than 40 species have been identified, although not all of those have been linked to disease in humans. But bottom line message is that IgG for Bartonella is highly specific testing, but is not sensitive for unclear reasons. And in studies in dogs, which are the best naturally occurring model for human Bartonellosis, Bartonella serology was shown to miss up to 50% of dogs that were ultimately shown to be infected with Bartonella by positive PCR testing. Here I just want to show this diagram from, this is one of the studies that was listed in the table that I previously showed of Bartonella seroprevalence studies in blood donors and healthy asymptomatic persons. What it shows, this is a study from Switzerland. If you recall, as I note on the left, the IFA titer of 1 to 64 has been historically considered the seroprevalence cutoff for showing Bartonella seropositivity. And yet, this is one of the European studies that showed strikingly high seroprevalence of Bartonella. And you can see each of those dots represents a patient with the titer on the y-axis. And a significant proportion of patients, as you can see, have titers of 64 or higher. So what I have here a quote from the paper that notes that based on the results reported here, a titer of 256 would have to be regarded as a cutoff level for our assay. And using this cutoff level, our test had a sensitivity of 100% and a specificity of 99%. And that is for patients with cat scratch disease. But in terms of assessing whether a patient has a history of exposure and infection to Bartonella, if you use a titer of 256, you're going to miss a lot of patients who historically would have been considered positive with a titer of 1 to 64 or greater. So in conclusion, PANDAS symptoms and signs overlap fully with neuropsychiatric manifestations of both Lyme borreliosis and Bartonellosis, aside from the emphasis in PANS or PANDAS on the abrupt dramatic onset of symptoms. And rather than being viewed as triggers of PANS, I think Lyme and Bartonella could be viewed as multi-symptom, multi-systemic infections whose neuropsychiatric manifestations include PANS-like presentations. Lyme and Bartonella seroprevalence rates indicate that there is a sizable proportion of asymptomatic healthy persons with subclinical or latent infection. This is not disease. And for Lyme, these studies are in Lyme endemic areas. For both infections, it's unclear what proportion of those persons will remain asymptomatic versus develop symptomatic disease, and what factors may predispose to one or the other outcome. So again, talking about a multiple hits model of infection, it's important to understand that not only a new primary Lyme or Bartonella infection, but also activation of a previously latent Lyme or Bartonella infection by other infectious or toxic triggers, for example, SARS-CoV-2 is one that I mentioned, may be a consideration in some PANDAS-PANS-like cases. Because of the limitations of serologic testing and diagnostic testing in general, it's important with Bartonellosis to recognize that cutaneous tracts or striae-like skin lesions, if present in patients with PANS-like presentations, are a valuable diagnostic tool for Bartonellosis. And clinical diagnosis is paramount with both these infections because of the limitations of available diagnostic testing. And lab testing should be seen as supportive or not of a clinical diagnosis. So just to provide some practical tips, which I didn't really go to in detail in my presentation, but I do think the commonly used interpretation criteria for Lyme IgG immunoblot testing, as I showed in several studies, has inadequate sensitivity in neurologic and neuropsychiatric disease. I favor obtaining Lyme immunoblot testing regardless of EIA results, and using a lab that reports more than the standard 3 possible bands for IgM and 10 possible bands for IgG. For example, labs that also report outer surface protein A, OSP-A, and OSP-B, which are highly Borrelia specific proteins. So you do not want to just count the bands. You need to know which bands are Borrelia specific, because if there are Borrelia specific bands present in the context of a clinical presentation that is consistent with borreliosis, you need to consider a clinical diagnosis potentially. Again, also sensitivity of Bartonella serology at standard commercial labs anecdotally is quite low. So I recommend using specialty labs. And if a patient is seronegative, but a symptom presentation is suspicious for Bartonellosis, consider doing Bartonella FISH testing or ddPCR testing. I'm not going to go into the details, but again, please see those 2 other CME courses on the Invisible International educational platform that go into detail on both Borrelia and Bartonella diagnostic testing. And here are my references. And thank you very much for listening.